So thank you very much. I understand that tea is more important than me, but it's good. So I'm going to give this talk as a surgeon. So I am a surgeon, but I'm going to talk about chemoradiation. This was sort of a shock to my system when I first got to UChicago in 2015, but I'm a firm believer in what I'm going to present. So we've all talked about the biology and aggressiveness of head and neck squamous cell carcinoma. And these are chance events that happen in driver genes that really lead from normal to cancer cells over time. So these are events that happen probably about 10, 15 years, over 10, 15 years, and it's microevolution that we see. It's why we're all here, evolution, but this happens over months to years, really in front of our eyes. So the challenge, and again, we go back to this is an aggressive tumor, the biology of this tumor is aggressive. So this is why it's aggressive, is here. So, we cut something out and we leave, let's say, a few cells here, here, and this whole process happens all over again. And that's what makes our jobs very, very difficult. So oral cavity, everyone accepts, including me, the standard of care is surgery, followed by adjuvant treatment based on pathology. And so I admire, Devendra and the Dr. group for pushing the limit, being innovative, and I think this is just another way to sort of push the limit. If our outcomes were 90, 95% 5-year survival, then I would be wrong coming up here and talking to you about an alternative. But we're not even close to that. So we have to do better. So concerns regarding primary chemoradiation are poor efficacy, which I'll tell you it's not true. Excessive toxicity, yes, surgery has its toxicity, and so does chemoradiation. And then I'm going to talk about the University of Chicago approach, where we've used definitive chemoradiation for advanced stage oral cavity squamous cell carcinoma, and who would otherwise require near total or total gastrectomy. So the question was asked, which organ are you saving? So the VA laryngeal trial, we were saving the larynx. Devendra talked about saving the mandible. We're talking about saving the tongue. This is for patients, again, not for early stage, not for early stage cancers. It's for cancers that will require almost near or total gastrectomy. So we're not advocating for early T1, T2. So this is just a database in terms of overall survival for oral cavity squamous cell carcinoma. And you can see for all comers, it's about 60%. And if you break it down per stage, so stage 4 is pretty abysmal, where 5-year survival is below 40%. And then the NCCN guidelines allow innovation to happen. So for T1, T2, N0, so early stage cancers, we already discussed this pretty extensively. Surgery with neck dissection or sentinel node is the treatment of choice, and there's no disagreement, and I am not addressing this patient population in this talk. But for the advanced T3, T4, surgery again is mainstay. We've had great talks about this. But clinical trials are an option. And again, we have to do better. Our outcomes are not adequate. So I'm going to talk to you about some of the clinical trials that we've been doing. So classically, CRT for oral cavity, it's an absolutely no. People ridicule these programs and like, you guys don't have good surgeons. And so we're not talking about operability. We're talking about improving outcomes and trying to maintain some function. And this is a similar case to what Alok presented from the first session yesterday, where I did bring up that this is an option, induction chemo followed by chemoradiation. So these are US T4s, not Indian T4s, but T4 regardless, which the patient underwent induction chemotherapy followed by definitive chemoradiation without any surgical intervention. A lot of the TATA trials are induction, surgery, adjuvant. So this is no surgery in this case. You can see the excellent response. So if we have accepted that we're going to save larynxes with chemoradiation, what I am proposing is no different. So we are going to save tongues with chemoradiation. We accept laryngeal dysfunction with chemoradiation. We also will have some dysfunction. I'll talk about osteoarterial necrosis in about 20% of the cases we see. But this is, for me, very similar. Near total glossectomy has poor outcomes in terms of quality of life, dysphagia, speech, articulation. So this sort of addresses all of this. So my answer is yes. CRT is a reasonable alternative for advanced stage oral cavity cancer. So this is Grant Achatz. He's a chef at Alinea, which is a Michelin 3-star restaurant in Chicago. He had advanced stage oral cavity cancer, which is treated at our university with chemoradiation. He's lectured widely, very sort of a pioneer in molecular gastronomy, and really a world-leading chef who did not want to lose his ability to sort of eat, swallow, taste, and sought an alternative approach. So what we've done is we've evaluated our patients over 2 decades, and from 1994 and then 2014, and then looked at the decades separately, so 94 to 2004 and then 2004 to 2014. And our induction chemo regimen is taxane and platinum-based chemotherapy for 6 to 8 weeks, and then concomitant chemoradiation. So this is, I think, where we get in trouble, because we do have sort of an atypical chemo regimen. We are transitioning more to cisplatinum backbone, but I think this is where people are like, what are you guys doing, hydroxyurea and all these things. But I'll show you the outcomes speak for themselves. And then followed by radiation to about 70-75 gray for gross disease and 50 to 60 gray for high-risk microscopic disease. And then in that second decade, 2004 to 2014, we use IMRT. So this transition happens. So these are our outcomes. So the median age was 55. We've talked multiple times about the decreasing age of this patient population, so we're also seeing it. So the total number of patients was 140. And we don't have the same volumes here, and this is over 2 decades. You guys would do this over 2 months. So we would definitely sort of need help to like extrapolate this data into randomized studies. But we probably couldn't do it in the U.S., and there's too many dirty politics in the U.S. between sort of multi-institutional collaborations, which Anil is advocating, but really hard to execute. So the primary sites, tongue were about 50%, and then floor mouth about 25% extending into the tongue. Retromolar, trigone, and other sites were less common. And then the vast majority of these were stage 4. And so they were driven, so I don't have the slide, but they were driven by both T, mostly T classification, and a minority by N classification. But these were mostly T3, T4. And then these are the outcomes. So of 140 patients, so overall survival with 5.7 years. The 5-year overall survival is 63%, and the progression-free survival is almost about 60%. So with the 5.7 years of follow-up median. And then this, again, I went back to the original slide. So mostly stage 4 cancers driven by T classification with a 5-year survival of 63%, where we reviewed sort of the database studies that reveal a 5-year survival of stage 4 below 40%, so 37%. So pretty significant improvement. And then this is, you see this with local regional control, where the 5-year local regional control is almost 80%, and distant control is almost 90%. And then we broke out the analysis by decades, so 1994 to 2003, and then 2004 to 2014. So IMRT is in the second decade. But you can see the overall survival, progression-free survival, local regional control, and distant control are all a little bit better. the more we learn about what we do and more about this disease process. So we had significant outcomes with pretty good prognosis and survival. There were 21 patients out of the 140 who had local regional failure, and the vast majority of these patients do die of this disease. So if this treatment fails, you can't salvage these. We've tried to salvage them, but it's really a minority of patients, so only 3 out of 10 where salvages have been successful. So I would say if patients don't respond to concomitant CR, induction followed by concomitant, they're going to probably die from their disease. There is toxicity. The induction and the concomitant regimen is not easy to tolerate. So the mortality from the treatment was 6%, and the majority of that was due to sepsis. So again, we're getting better in the second decade managing these things, but there is mortality related to the treatment. And then the swallowing, so the median score was 4, and with mild to moderate impairment, and about 15% G-tube dependence. So this is where sort of everyone fears chemoradiation for oral cavities, osteoarterial necrosis. So we had an incidence of about 19-20% of ORN that was symptomatic. So symptomatic means that there's exposed bone, bone is spitting, but that doesn't necessarily mean that you have to do a segmental mandibulectomy with fibula. And when we looked at just ORN, what the significance, the site of significance was really the floor of mouth with an odds ratio of almost 7. So floor of mouth, which makes sense, the radiation field is close to the mandible, there's a much higher incidence of osteoarterial necrosis. So, in conclusion, definitive chemoradiation for advanced stage oral cavity squamous cell carcinoma is a possibility. Again, it's sort of going against what we all think about for management of oral cavity, but I would say we have to be open-minded. The control is comparable or better to some of the published series. The function is satisfactory. And yes, there's about a 20% incidence of ORN with primary floor of mouth cancers. And it wasn't that different even with IMRT. So osteoarterial necrosis is a major concern in this treatment paradigm. So some novel approaches. So, you know, every time we try to think differently, there's always a push. So immunotherapy has been around for over 50 years, and everyone is very skeptical about it. And only now, over the last few years, the field, oncology in general, not just head and neck, is accepting this. So, you know, past work, there was vaccine trials, other modulation, using antibodies, but now we have effective studies. We have HPV vaccination, which is very effective. We have checkpoint inhibitors, and the future is great. And so beyond sort of immunotherapy, I think things like being open-minded about different approaches to cancers that we don't have control of, I think is going to be very important. So just one other thing that we're trying to do, so there's a high-risk patient population that doesn't fit into a paradigm that should get adjuvant treatment, but as surgeons, we worry about them. So what we're trying to do is sort of do a randomized trial with Pembro versus placebo with a crossover to try to address this patient population, has high-risk features, doesn't meet criteria for adjuvant radiation or adjuvant chemoradiation, but we have concerns. So this is just sort of a side note that we're trying to get some sort of maintenance therapy that may be helpful in a high-risk patient population. So, you know, I'm presenting something to you that a lot of people don't accept, but I've seen it work very effectively. I'm a strong, firm believer despite being very skeptical initially. So thank you. This is our head and neck cancer team, much smaller than the teams we see here. And then we welcome you to Chicago in 2020 for AHNS, IFNOS, and then ASCO. And when you're in town, please let me know. Thank you very much.
Nishant, interesting data. A quick question. What was the end stage for this T4? Because I guess most of them would have either unilateral or bilateral neck
Yeah,
metastasis.
so they were.
And did you address the neck surgically or treated with CTRT as well?
Everything was treated with CCRT.
So you sterilized the neck, you didn't have to operate the neck at all?
No.
In none of the patients?
No.
Not even salvage?
There were a couple of local regional
You did 10
salvages.
salvages?
Yeah.
Okay.
Yeah, but not outside of that.
And how do you explain the 63% control rate, which is far better than any of the T4 that we treat conventionally?
Yeah.
Did you select your patients, or were they HPV positive, or?
No, these are all HPV negative oral cavity. Yeah, we wish. Yeah, no. So this is again, like I was very skeptical, but then the data is there, and so you see sort of the 140, but even like when we look at individual patients, it's amazing.